So good evening everyone and welcome all to BOA PG lecture series. As all of you know, we take one specialty lecture every once a month and last month we did lecture on disc edema. But since it's a huge topic and we wanted to cover it all and not to do any injustice to the topic, we kept it as a part 2 for the remaining differential diagnosis of the disc edema. And to continue with the same, we have Dr. Susha ma'am with us. Welcome, ma'am, and thank you for giving your time. And she will be continuing with her disc edema lecture part 2. And over to you, ma'am.
Thank you. I'll start sharing my screen. I assume you can see my screen.
Yes, ma'am. Can see.
Yes?
Yes, yes.
Okay.
Full screen. Yeah.
Yeah. Okay. A very good evening once again to everybody. So, thank you, BOA, Dr. Swapnesh, Dr. Sumit, for giving me this opportunity again. It's great to be in a teaching session, and I hope I can cover whatever I know about disc edema. So, am I audible, Sumit?
Yes, ma'am. Very much, very clear.
Okay. So, different strokes of disc edema, part two. I would like to brush up a little bit on the last time we had talked about what is disc edema, what is the difference between disc edema, papilledema, and pseudodisc edema. We had talked in detail about idiopathic intracranial hypertension, and a few points that I would like to stress upon is papilledema is when there is a disc edema with an associated raise in intracranial pressure, generally in women who are obese and have these symptoms of headache, tinnitus, maybe diplopia due to sixth nerve palsy. We should always suspect idiopathic intracranial hypertension. The criteria for diagnosing idiopathic intracranial hypertension, as I mentioned last time, by the revised or modified Dandy's criteria, was that it should be associated with raised intracranial pressure. There should not be any other etiology or any other SOL or anything that is detected on the MRI. There has to be a raised intracranial pressure by lumbar puncture of more than 25 centimeter of water. And the most important is that the CSF should not show any other abnormality. Keeping all this in mind, we will go further to the other differential diagnosis. Mostly the rest of it are unilateral. Some of them may be bilateral, subsequential. And let us see what we have. So the first one would be optic neuritis, much more commonly observed. Also is ischemic optic neuropathy. So optic neuritis is the inflammation of the optic nerve causing a reduction in visual acuity, function, and or visual field loss. So visual field loss may or may not be present. Inflammation affecting the ophthalmoscopically visible part of the nerve at the disc and thus showing obvious signs of disease is seen in papillitis and neuroretinitis. So that is what differentiates papillitis and neuroretinitis from retrobulbar neuritis, in which the inflammation, though it attacks the nerve, it is proximal to this region. And so ophthalmoscopically, we don't see a disc edema. Though the patient complains of visual loss, dyschromatopsia, pain on eye movement, we really don't see anything on the disc, and that is when we label it as retrobulbar neuritis. To explain the pathology, there are three types of neuritis. This is for your knowledge only. Generally, in practical exams, you might be questioned because there are newer entities in optic neuritis other than multiple sclerosis, which are the fundamental pathology behind the optic neuritis being present in the patient. So demyelinating diseases other than multiple sclerosis have been identified, and that is why these three types of neuritis is very, very important. First would be perineuritis or periaxial neuritis. The leptomeninges of the optic nerve are inflamed and may represent a spread from the brain and orbit or sinuses. It may extend along the pile septa into the nerve parenchyma, affecting the extramacular fibers. Axial neuritis, where the macular fibers are more affected, and that's why it causes centrocecal scotoma and temporal pallor of the disc. Example, multiple sclerosis. Also, in toxic and nutritional neuropathies, central or centrocecal scotomas are found because the macular fibers are more affected. So the neuritis is more axial. Transverse neuritis, both the axial and the periaxial neuritis may progress to involve all the fibers. So generally, the visual field effect is more in these cases. Etiology, as we all know, it is given in the books. It may be idiopathic, demyelinating, infectious, and so on. So idiopathic, the demyelinating, multiple sclerosis, ADEM, neuromyelitis optica or NMO as we call it, diffuse periaxial encephalitis or Schilder's disease. Infectious may be local or systemic, local including endophthalmitis, orbital cellulitis, sinusitis, or contiguous spread from the meninges, brain, and the base of skull. Systemic infections may be bacterial, viral, protozoal, fungal, or parasitic as follows. There may be immune-mediated disorders like a local uveitis or sympathetic ophthalmitis causing a disc edema. Systemic causes like sarcoidosis and Wegener's granulomatosis and acute disseminated encephalomyelitis, ADEM, may also be there, especially in younger children, very small children. ADEM is common. The clinical features, it's more common in women, as is IIH, if you remember, 20 to 40 years of age. So when the patient presents to you above 40 years of age, you should always be cautious about labeling it as an optic neuritis, a typical optic neuritis, a demyelinating optic neuritis. The visual loss usually is unilateral in adults, though we have seen bilateral cases, but in children it is generally bilateral. May start with one eye, but generally by the time the patient presents to us, it might show bilateral disc edema, maybe incongruous though. Pain increases on eye movement with elevation and adduction. Why is it elevation and adduction? Because if you remember the diagram of the superior orbital fissure, the same sheath with the optic nerve is shared by the superior rectus and the medial rectus, and that's why on elevation and adduction, the action of those muscles, you tend to feel pain if you have a nerve inflammation due to optic neuritis. Uthoff's phenomena and Pulfrit phenomena are seen in multiple sclerosis, where there is worsening of symptoms on exercise or a rise in temperature, like having a bath in hot water. And Pulfrit's phenomena is altered perception of moving objects. So even after the object has moved from the particular area, the patient can still see the object at the previous area. There is loss of color vision. Typically, there is red desaturation. There is reduced perception of light intensity. There is RAPD, relative afferent pupillary defect. Now, when the involvement is of both eyes, RAPD might be a little difficult to decipher. You might have cases in which both the eyes are simultaneously involved, and you might feel that the light reaction is not relatively defective. So that has to be kept in mind. Visual fields, like I said before, central and centrocecal scotoma is more common when the axial fibers are involved. The fundus may show vitreous opacities. In retrobulbar neuritis, there will be a normal optic disc and nerve fiber layer, but in papillitis, there will be disc hyperemia, peripapillary flame-shaped hemorrhages, and neuroretinitis may show disc hyperemia with a macular star. So this is a figure showing papillitis, and this is neuroretinitis. These are all representative pictures taken from standard textbooks. So when should you suspect that this is not a typical optic neuritis? When do you say it is not a typical optic neuritis? When the patient presents to you with, like I told you, above 40 years of age, when it's a male patient who's older in the age group, when there is an absence of pain, when the patient presents with a very, very gross loss of vision, like no PL, when there is marked optic disc swelling with retinal exudates and peripapillary hemorrhages, When there is a lack of recovery, even after a few weeks, after 3 to 4 weeks, you still see that there is no recovery at all. And when there is a bilateral involvement. So this is a picture of stellate neuroretinitis, in which there is no risk of multiple sclerosis. Cat scratch disease, syphilis, Lyme disease, HIV can show this kind of a picture. So look for a systemic cause when you have a neuroretinitis. Though it presents like optic neuritis, the prognosis is very good if steroids are given. And Leber stellate neuroretinitis only. Other forms of neuroretinitis which may be infectious need the particular treatment according to the diagnosis, not only steroids. And in some cases, steroids are best avoided. I'll be talking about it later. Pediatric optic neuritis is usually bilateral. Like I told you, disc swelling is more common, so retrobulbar is lesser common. More aggressive treatment is needed. Immune mediated, usually bilateral, post infectious, ADEM, like I told you, ADEM, and has a good prognosis. Idiopathic ones will show demyelination, and 10 to 50% eventually will develop multiple sclerosis. Okay, so there are a few pearls. Most common type of optic neuritis in children is, I just mentioned it to you, it's papillitis. And the most common cause of optic neuritis in children is post-viral episode. So what are the investigations that we should do when we see a case of optic neuritis? The visual fields, the perimetry will show a central or centrocecal scotoma. VEP will show a prolonged latency, complete blood count, RPR, C-reactive protein, ESR, FTABS, anti-nuclear antibody ANA, MOG and NMO antibody titers. So we will be speaking in detail about MOG and neuromyelitis optica, which are the newer entities like I told you. MRI brain and orbit with gadolinium enhancement with fat suppression. For multiple sclerosis, you have to look for periventricular plaques. For MOG, you have to look for perineuritis. And for neuromyelitis optica, you have to look for involvement of longer segments. The other things that you need to do are an X-ray chest, a mantu, and a sputum. All these tests need to be done before you start the steroids. Sarcoidosis also needs to, we need to evaluate with a X-ray chest and a gallium scan if you find that there is something significant. Blood sugars, and to rule out sinusitis, and X-ray of the PNS. So absolute essentials, if you really think that it is a typical optic neuritis and you are sure about the diagnosis, then a CBC, ESR, MANTO, and blood sugar in our setting in India, because TB is endemic, tuberculosis is endemic. So we need to do these tests and a chest X-ray before you start with the steroids. Here is a small table differentiating between Devick's disease and multiple sclerosis. Don't copy it down. I'll be sending across the PPT to Sumit and you can take it from him. So a few things that you need to know are neuromyelitis optica and MOG, myelin oligodendrocytic disease. These two spectrum of diseases are the demyelinating spectrum of multiple sclerosis was the only one which was explored before. So in recent times, we know that when a multiple sclerosis is behaving, when an optic neuritis is behaving in a different manner, when it is atypical, when on the scan, the perineuritis is more common or longer segments are involved, and the patient complains with some spinal issues as well, with weakness of limbs, etc. You have to consider NMO and MOG, and especially if the optic neuritis is recurrent. So what is the difference between the two is in multiple sclerosis, when we do the CSF, we see oligoclonal bands, which are absent in Devick's disease. Permanent disability is usually in the late progressive phase in multiple sclerosis. These are the reasons why it is very, very important. Whereas in NMO, it may be attack related. And the visual loss in NMO is much more than in multiple sclerosis. In multiple sclerosis, generally the visual recovery is way better. So, and the most important one is aquaporin 4 antibody or NMO antibody, neuromyelitis optica antibody, is present in Devic's disease, which is absent in multiple sclerosis. So if a case of optic neuritis presents to you, you have to first differentiate whether it's a typical optic neuritis or an atypical one. Get the brain MRI done, and if it is normal, you consider intravenous corticosteroids on a case-by-case basis. So when do you refer the patient to a neurologist to rule out multiple sclerosis? When there have been recurrent episodes, and even though the MRI has not picked up any multiple sclerosis lesions, you have to refer the patient to a neurologist in order to keep him on a watch. And if you see that there are lesions, then obviously other immunosuppressives need to be started. If the MRI is abnormal but consistent with demyelination, intravenous corticosteroids and immunomodulatory therapy need to be considered. If it's an atypical case, there is no pain, retinal exudates, retinal hemorrhages, disc is severely swollen, and there is no visual recovery after 1 month, then consider it may be an ischemic optic neuropathy, infiltrative optic neuropathy, inflammatory, infectious, or compressive optic neuropathy. So MRI and serological studies as appropriate for the following should be done. In an attack of optic neuritis, if there are no demyelinating lesions, then recurrent attacks of optic neuritis, appearance of demyelinating lesions later on, and appearance of neurological symptoms, like I told you, you have to refer to a neurologist and discuss interferon therapy. Optic neuritis treatment trial, ONTT. So what is this all about? So like you know, in optic neuritis, the treatment is basically giving IV methylprednisolone, and now even IV dexamethasone has been approved. So in the optic neuritis treatment trial, which was initiated in 1988 and went on till 2006, in the trial, there were 3 groups. That is, one group was given oral prednisone, one was given IV methylprednisolone, and the third group was given oral placebo for 14 days. And in this trial, they found out that IV steroids given for 3 days, 1 gram IV methylprednisolone in 4 divided doses, that is 250 mg 4 times a day, followed by oral steroids 1 milligram per kg body weight for 11 days is what was the most effective. There was no difference between the steroid group and the placebo group when the visual acuity at the end of 6 months or 1 year was considered. But IV steroids do accelerate the recovery by 2 to 3 weeks. If only oral steroids were given 1 milligram per kg body weight, then it doubled the recurrence in either eye. And lack of at least 1 line improvement in the visual acuity within the first 3 weeks after the onset should be considered as an atypical optic neuritis. So if the patient presents to you for the first time and you have already done the MRI for the patient, considering it is a typical optic neuritis case, based on the initial MRI in isolated typical optic neuritis at 15 years after the attack, if there are 0 lesions, then the risk of getting multiple sclerosis at the end of 15 years is very less. If 1 to 3 lesions, 4 to 10 lesions, or more than 10 lesions, there is a very high risk, that is more than 75% chance of having multiple sclerosis at the end of 15 years. Risk of multiple sclerosis if the MRI is normal and any one of the following factors are present is nil at 15 years, as they point to a different etiology. So if there is no pain, no PL at initial presentation, if there is a severe disc edema, if there is a hemorrhagic disc edema, and there are retinal exudates, and you have found out no other etiology for the optic neuritis, then the risk of MS is very, very less. The MRI, a brain and orbit, and because we have this new entity of neuromyelitis optica, MRI spine should also be suggested when the patient comes to you. And it should ideally be done in the first visit itself, otherwise it's very tedious to get the patient back. And again, because the vision is not recovering, we again ask them to go ahead and do the test. Generally, an MRI brain with orbit with contrast, gadolinium enhanced contrast, a fat suppressed image is what will give you the perfect picture. Don't forget anti-aquaporin 4 antibody and anti-MOG antibody in all typical cases to rule out neuromyelitis optica and MOG spectrum of diseases. Pay special attention to the elderly age group where there is bilateral involvement, where there is a long optic nerve segmental involvement on MRI with sheath enhancement or chiasmal involvement, or no improvement with the conventional ONTT regime. When required, immunomodulating drugs are to be started to reduce the development and severity of chronic demyelinating multiple sclerosis, reduces the antigen presentation, inhibits the pro-inhibitory cytokines, and inhibits the autoreactive T cell induced immunosuppressive cytokines, and it decreases the migration of cells in the central nervous system. So interferon beta, interferon beta 1 and 2, Avenex as referred by the CHAMPS study. You can go through the ONTT protocol, the CHAMPS study, and the benefit study. For your vivas, it might be beneficial to mention and to know what exactly the study is about. Or intravenous immunoglobulin treatment as well. So one more thing I would like to mention is if there is NMO, there is plasma exchange that they do. And in MOG spectrum of diseases, higher dose of steroids, IV steroids for a longer time. And even when the oral drugs are given, it is given at least 60 to 100 milligram per day, as compared to multiple sclerosis or typical optic neuritis, where we give 1 milligram per kg body weight per day for 11 days only without any taper. We go on to the next topic, anterior ischemic optic neuropathy. It's defined as an acute painless optic neuropathy occurring secondary to optic nerve ischemia. It is of two types, basically, anterior and posterior ischemic optic neuropathy, as the name suggests, whether affecting the anterior part of the optic nerve or the posterior part. AION and PION, as we'll be calling it. AION may be arteritic or non-arteritic. PION may be arteritic, non-arteritic, or surgical induced. Let us go to arteritic AION, which is caused by giant cell arteritis. Patient might present to you with polymyalgia and an angry looking disc. At diagnosis, around 50% of patients will already have GCA, while around 20% will develop GCA later on. Polymyalgia is characterized by pain and stiffness in the proximal muscle groups, typically the shoulder and biceps, that is worse on walking. So what you need to see is this angry disc, and there is pain in the temporal area, and you can see the abnormal artery, and a biopsy should be taken, which will show mononuclear cell infiltration or granulomatous inflammation. The temporal artery will be tender to touch, and on palpation, you might feel the pulsations decreased, and the patient will complain to you about temporal kind of a headache. And generally, these patients are in the older range as compared to typical optic neuritis. Ischemic optic neuropathies are generally seen in patients who are above the age of 40, unless the patient has some other ischemic factors at a young age. So there is this criteria by the American College of Rheumatology, in which there are 5 points which are given, and out of these, at least 3 should be fulfilled in order to label the patient as having giant cell arteritis. And yeah, for NAION, there are multiple factors which are responsible. So, as we know, the most common of those is hypertension, diabetes mellitus. All of these will not only alter the flow of blood in the blood vessels, or as well as the viscosity or the thickness. So, hypertension, diabetes, cardiac diseases, collagen vascular diseases, thyroid, vasospastic disorders, and hemorrhagic shock can all lead to NAION. The ocular causes may be an absent cup in a high hypermetrop, a small cup, raised intraocular pressure, or prolonged pressure on the eyeball. Nocturnal arterial hypotension plays a very important role, and so it is very important to ask a patient who presents to you with NAION and is on antihypertensives whether the dosage is nighttime dosing. If it is, just changing the dose to a morning dose might really relieve the patient of the problem, and a recurrent attack in the other eye may be prevented. So the pathogenesis of NAION is that there is occlusion of the short posterior ciliary arteries, which leads to a decreased blood supply to the optic nerve head and causes an infarction of the optic nerve head. So I want you to remember the pathogenesis of NAION versus the pathogenesis of papilledema, which was solely dependent on the intra-axonal pressure, or the difference between the intra-arterial pressure and the intraocular pressure. These are the differentiating characteristics between an arteritic and a non-arteritic NAION and AION. So in these two ischemic neuropathies, most of the characteristics have been given in this table, which also gives the definition and the features that are seen in each of them. So like I mentioned before, the age group might slightly vary. In arteritic, it will be really above 70 years, and non-arteritic between 60 to 70, though I have mentioned above 50 in the previous, because there are cases now of patients above 50 getting an EION. More common in females. In arteritic, there will be jaw claudication, headache, scalp tenderness, which is not seen in a non-arteritic ischemic optic neuropathy. Ocular symptoms are highly suggestive. NAION patients will rarely have, and I would like to mention that since the visual field also is affected in an altitudinal manner, and the central vision field might still be clear for the patient, and he might not complain of a gross visual loss. This is also highly contradictory to excuse me, to optic neuritis, where vision loss will be the first complaint. So visual loss is highly suggestive in arteritic ischemic optic neuropathy as compared to non-arteritic, where only 20% of cases will come with a primary complaint of visual loss. Pain is seen in arteritic as well as in optic neuritis, which is rare in non-arteritic. The second eye involvement is 75% of cases within days or weeks. In arteritic ischemic optic neuropathy, it will be involved. In months or years, 40% may get involved, and you have to look for a disc at risk in the other eye, a very small, angry-looking red disc with a very small or diminished cup. The disc appearance will be chalky white swollen disc in arteritic ION, and a sectoral or pallid in non-arteritic. When you do an FFA, there will be a disc filling defect plus a choroidal filling defect in arteritic cases, whereas there will be only disc filling defect in a non-arteritic case. ESR will be raised, and it will be normal in non-arteritic. CRP will also be raised, and a temporal artery biopsy will be positive in arteritic. The response to steroids will definitely be there in an arteritic, and that is how we treat an arteritic ischemic optic neuropathy, whereas it is pretty controversial in NAION, the use of steroids. Most of us I personally don't use steroids in non-arteritic ischemic optic neuropathy, but there have been arguments on the other side saying that the immediate disc edema, if it's a case which has symptoms only since the past 2 or 3 days or within the first week, administering steroids do help reduce the edema. On the other hand, long-term use of steroids have also been reported to increase the chances of getting an ischemic optic neuropathy in the other eye. So, surgery for ischemic optic neuropathy, whether an optic nerve fenestration surgery would help, was of debate, and there is a study in which they compared the ONSD study in 119 patients with no treatment in 125 controls. They revealed no significant benefit for treatment, and it was recommended that ONSD not be performed. Other things that were tried was hyperbaric oxygen by marked elevation of the dissolved oxygen content in the blood. It provides an increase in the tissue oxygenation and might reduce damage in irreversibly injured axons. A clinical pilot study of hyperbaric oxygen in 22 patients who had acute NION, however, has shown no beneficial effect. Neuroprotective agents, especially brimonidine, have shown a beneficial effect in animal models of optic nerve damage, but are not yet proven to be effective in NION. The effect of aspirin in reducing the risk of fellow eye is still unclear. Like if you have NAION in one eye, mostly neurologists, when you send the patient to a neurologist, they do start with an antiplatelet or aspirin. And whether or not this is beneficial in preventing an attack in the other eye is highly controversial. Now let us talk a little bit about posterior ischemic optic neuropathy. It is uncommon. I have seen about 2 cases in my practice as of now. It's caused by a retrobulbar optic nerve ischemia. It is caused especially because of the ischemia of the pial arteries. It is diagnosed only after exclusion of other retrobulbar optic neuropathies. Just because you don't see a sign, you should not immediately diagnose it with PION. PION is a diagnosis of exclusion. Pathogenesis of PION, there is decreased oxygen carrying capacity. Hypotension leads to a decreased perfusion pressure, and there is increased resistance to the blood flow. The 3 subtypes, as I had mentioned before, arteritic may be associated with GCA with a poor visual prognosis. Non-arteritic with the same risk factor of NAION, but not associated with a crowded optic disc. And perioperative, mainly in spinal and cardiac bypass surgeries and in surgeries where there has been hypovolemia or a lot of blood loss. Within hours to days, PION has been seen in cases. Investigations are the routine investigations that we do for NION. ESR, CT or MRI, a VEP will show a decreased amplitude. There is no effective treatment. Some treatment methods attempted were correction of the hemodynamic derangements, systemic corticosteroids, antiplatelet therapy, and measures to lower IOP. But unfortunately, PION generally has a very, very bad visual prognosis. Now we come to diabetic papillopathy, which is also a disc edema, which at times is misdiagnosed to be an optic neuritis just by seeing the angry disc or the disc edema. At times, if you don't thoroughly examine the rest of the retina, you might miss other changes of ischemia that are there. So it is an atypical form of NAION. It's not classified in NAION, but the etiology is kind of similar. The symptoms include no visual symptoms, non-specific. It can be either of the 3. The patient might present with absolutely no visual symptoms, There might be a minimal visual disturbance such as painless, mild blurring or distortion. Visual acuity is usually normal or mildly diminished, except the coexisting diabetic maculopathy will be there with a macular star. So this diabetic papillopathy with a macular star is a differential diagnosis to neuroretinitis with a macular star. The optic nerve will appear non-specific hyperemic disc swelling or a prominent dilated vessel mimicking neovascularization might be present on the disc surface. In the setting of bilateral disc swelling, we have to differentiate it from papilledema. So if the patient is presenting to you with a bilateral disc swelling, an angry looking disc, you have to look for other signs, whether it can be a diabetic papillopathy, it can be a malignant hypertension, it can be papilledema. So invariably, these patients do tend to undergo tests like an MRI and CSF opening pressure by LP, and so they will. The CSF opening pressure will let us know whether it is a papilledema or not. The BP and the sugar will let us know whether it is a diabetic papillopathy or a malignant hypertension. The visual field test may show an enlarged blind spot, which is also similar to what we get in papilledema, an occasional arcuate or central field defect. The optic disc swelling usually resolves within 2 to 10 months with residual mild optic atrophy. Long-term visual prognosis depends on the presence and extent of diabetic retinopathy and very rarely the progression of this papillopathy to an AION. The other cases where we can see a disc edema, rarely or mostly it is disc atrophy that we see because these may tend to go unnoticed. That is, I'm speaking of nutritional optic neuropathy, which may go unnoticed. Toxic will generally present after months of use of a particular drug. So if there is an unexplained sudden or chronic vision loss, always revisit the history to rule out a toxic optic neuropathy or nutritional optic neuropathy. Do not forget to take the history of drugs like chloroquine, ethambutol, linezolid, isoniazid. I'll be giving a full table in the next slide. Again, a baseline examination will include all visual function tests like color vision, contrast with an OCT macula, fundus photo, and they have to be followed up closely until after stopping these drugs. Here is a list of the drugs. So I would like to mention that methanol, ethylene glycol will always show an acute visual loss. So, excuse me. And ethambutol, linezolid will show kind of a bilateral optic neuropathy with an insidious onset. And they will generally be with prolonged use. The disc may appear normal or edematous, and if it has gone unnoticed, pallor might have set in. With vitamin deficiencies, there might be an acute or gradual loss depending on like if there is a thiamine deficiency and then is a Wernicke's encephalopathy, you might see it very sudden, the visual loss. Whereas if it is a chronic, vitamin deficiency, you might see a pallor after a long time when all the other etiologies you have been able to rule out. You might think of vitamin deficiencies as well. So in order to distinguish a vitamin deficiency or a toxic optic neuropathy from the rest of the causes of a disc edema, you always have to revisit history and be thorough with your examination. And when you are advising, if you have even the slightest doubt, you have to advise a toxicity profile and your blood vitamin, serum vitamin levels, serum iron, calcium, and vitamin levels, so that you can treat accordingly. Non-ischemic CRVO or anistemic CRVO may also present with disc edema, which you can see the rest of the fundus and it is self-explanatory. So an FFA will fundus fluorescein angiography will tell you whether it's a venous occlusion that you are dealing with. Hereditary optic neuropathies, especially Leber's, will also be can also be confused as an optic neuritis. The disc will appear hyperemic. Obscuration of the disc margins will be there. There will be dilated capillaries on the disc surface. That may extend to the surrounding retina. They are called as telangiectatic microaneurysms. Additional features that you can see is the swelling of the nerve fiber layer, dilation, tortuosity of the posterior pole vasculature, maternally inherited mitochondrial DNA mutations are what cause this, and it is seen more in males between 15 to 35 years. It's a subacute, painless, severe loss of vision in one eye followed by the other. And the vision loss is severe and irreversible. So it's an X-linked recessive disease more in men in the second to third decade, unilateral sudden loss of vision. The features that you need to remember, like it is seen here, is disc edema with hyperemia, with telangiectasia and an edematous nerve fiber layer. Secondary optic atrophy will set in later. The fields will show a dense central or centrocecal scotoma, and there'll be mild spasticity and gait disturbances that you need to check on. Compressive optic neuropathies can also present with disc edema. Disc atrophy also sets in. If there is a disc edema and the pallor is not as visible, you have to look for optociliary shunt vessels. You may also have a case of disc edema in one eye and atrophy in the other. This is Foster Kennedy syndrome. Do rule out pseudo Foster Kennedy syndrome, like I had told you in my last lecture. If one eye has had an attack of NAION or AION a few months back, a little time back, and pallor has set in that eye, and the other eye comes with a fresh disc edema, you might confuse it with Foster Kennedy syndrome. It is called as pseudo Foster Kennedy syndrome. So before you advise your MRI and counsel the patient, be sure that it is not a pseudo Foster Kennedy syndrome. It's rare. It is seen in the frontal lobe tumors. Additional features seen in optic nerve gliomas, meningiomas, glioblastomas, and aneurysms is a slowly progressive visual loss, proptosis, gaze-evoked amaurosis. So the Foster Kennedy syndrome is seen in frontal lobe tumors. If it's a compressive optic neuropathy due to a local tumor like glioma or meningioma, there will be slow progressive visual loss and proptosis and gaze evoked amaurosis. So if the patient has a tumor and the patient is looking from right to left, there might be a sudden episode of loss of vision. You can see that frontal lobe tumor, which has caused optic atrophy on one side and optic disc edema on the other side. What are the investigations that will help you differentiate between the different types of disc edema? What is the etiology? The first, like I told you, is a visual field. In papilledema and perineuritis, there will be an enlarged blind spot and nasal arcuate scotomas. In AION, we are expecting altitudinal defects. In a tilted disc, you are expecting a bitemporal hemianopia, which does not respect the vertical midline. So there is hemianopia, but it does not respect the vertical midline. Fundus fluorescein angiography will show a disc capillary dilation, dye leakage in papilledema. In AION, arteritic AION, choroidal phase will show a delayed filling, as well as the disc will show delayed filling. In NAION, there will be a delayed disc filling and segmental disc fluorescence because of surface telangiectasias and the long-standing ones. Neuroretinitis, there will be no leakage at the macula as compared to diabetic papillitis, where there will be leakage at the macula. Hypertensive retinopathy, there will be leakage from the small vessels at the macula. OCT is also very essential in disc edema. So there is this beautiful article which has recently released in the Survey of Ophthalmology by Dr. Amar Pujari. I have kept the link also in the box so that you can go and read about it. In that article, the use of OCT in each type of disc edema, each type of disc atrophy has been given. And what I would like to mention is the recent studies have shown that OCT can detect a lot of changes, especially damage to the optic nerve, the axons, much before the fields can pick it up. So actually doing an OCT scan of the macula and a ganglion cell and nerve fiber layer will actually tell us how much ganglion cell loss and axonal loss is there as compared to the fields. So it is even useful in papilledema and in AIONs to prognosticate how much vision will remain after the end of the episode. In fact, if we do the RNFL and GCC of the unaffected eye, you can also come to know how much, especially in ischemic diseases, how much of a chance there is that the other eye is also going to be affected by a vision loss by quantitatively assessing the amount of fibers that have undergone damage. Neuroimaging, you can do a CT scan in patients whom you're suspecting a tumor or a hematoma post-injury. If you have, if you're suspecting an abscess, or if it's a compressive optic neuropathy like in tumors. So I would generally go in for an MRI, but there are cases where you need the CT, especially in cases where it's a trauma and you want it done immediately and where MRI is not available. Because MRI is also the costlier modality. At times, a CT will also help. In fact, even in IIH, CT will show a little bit of flattening of the posterior part of the globe and an empty cella. So in MRI, a brain in multiple sclerosis will show periventricular plaques, as I've shown here. In idiopathic intracranial hypertension, it will show an empty cella. In a cerebral venous thrombosis or an arteriovenous malformation, we might need an MR venography or angiography. The other things that you can suggest is gadolinium enhancement with contrast and fat suppression, which is really important in inflammatory lesions like optic neuritis. So the idea here is that when we are ordering an investigations, we have to have a rough idea of what we are looking at. If you think that the edema is a papilledema, and it might have any other cause than a tumor or a compressive lesion, you should always order it with an MR phenogram. If you're suspecting, if the patient is obese, she's a woman and she has some hormonal dysfunction, or she has a thyroid, and you're suspecting that it may be an IIH, then you should always order it with a venogram. If you are getting the other findings which are suggestive of an arteriovenous malformation, you should advise an MR angiogram along with it. If you suspect that the ischemia may be because of thrombus, also you should advise the investigations accordingly. Whether or not a contrast is required is also after you assess the situation and plot down your differential diagnosis. The blood investigations, grossly, we have to check the BP and, oh, I'm sorry, what just happened. Yeah. The blood investigations will be for polycythemia, CRVO and IIH, hypercholesterolemia, serum homocysteine and NaION, ESR, aquaporin 4 IgG, MOG, anti-MOG antibodies, blood sugar, ANA Lyme titers, FTA, Hebis, and atypical optic neuritis. Though we don't see many cases of syphilis in our country, we see more of TB and sarcoid. We have to do all these tests. When we are doing a CSF analysis, we need to note three things. First is whether there is the opening pressure is high, that is, it is about 25 centimeter of water. 20 to 25 is still in the gray area, like I had told you last in the last class. Multiple sclerosis will have oligoclonal bands, and meningitis or any other infectious condition will have a decreased glucose, increased proteins, and also WBCs should be noted. A B scan will help us differentiate between a pseudodisc edema and a disc edema, like if it's a disc drusen or if there is the T sign of the posterior scleritis. Surgery in neuro-ophthalmology for disc edema is done mostly only for IIH. I'm speaking of the ophthalmic surgery. Of course, if you have a tumor or some space occupying lesion that the brain needs surgery, the neurosurgeon takes care of it. For us ophthalmologists, it's necessary to know about the surgical decompression done in IIH, that is an optic nerve sheath fenestration surgery. When there is a failure of medical treatment, when there is a marked disc swelling more than 5 diopters, when there are engorged veins, extensive hemorrhages, progressive optic neuropathy, there is an early field constriction. When there is an all these conditions, then we have to do an optic nerve sheath decompression. One of my neurosurgeon friends did argue that optic nerve sheath fenestration is one of the first modalities that you go to when you're seeing a patient with IIH. It depends purely on the rate of progression of visual loss, as well as on the first visit, what is the visual loss that you are seeing. If it is really significant and the systemic symptoms are lesser, and a lumbar puncture is showing that the pressures are not that high, then and only I would say that we should go in for an optic nerve sheath fenestration before trying acetazolamide and weight loss. So the surgical options I had told of the last time itself. For ophthalmologists, we need to know optic nerve sheath decompression and bariatric surgery in order to lose weight. Frequent lumbar punctures. So every time there is a lumbar puncture, the pressure decreases and the patient gets relieved of symptoms. But instead of doing it frequently, there is the surgery of placement of lumboperitoneal shunts is what is preferred, or a subtemporal decompression as well. So with this, I finish this lecture, and we are going to the cases. The two cases that I'm going to present to you. Sumit, can we have poll on these cases? Hello,
Yes, ma'am.
Sumit.
Yes,
Yeah,
sir.
yeah.
Uh,
Can we have
I,
poll on these cases?
when the clue is written. Okay. So fine. I will just launch the poll. All of you can answer it, and will.
Yeah, I will just read out the question once.
Yes,
A
ma'am.
45-year-old female with decreased vision and eye pain presented to me in the OPD. She is obese, has been on medications for diabetes since 2 years. It is in control. The HbA1c is 5.6. The vision is 6 by 18 in both the eyes. The intraocular pressure is 16 mm of Hg. The anterior segment shows occasional cells. The fundus shows vitritis, disc edema, and a macular star. The clue is meow. She owns cats. So it's I mean, with the clue, I think I have given it all, but you can look at the options and launch the poll.
Launch the poll now.
Yeah.
I hope everyone can see. Please start answering it. It's A, B, C, D. 20 more seconds to go. There are a lot many people more can answer. Don't worry, we don't come to know who has answered. You can just keep answering.
This one is a very easy question. I hope they all get them right. This last time I was pretty. I was feeling I did not. I kind of failed them by giving them such tough questions. But this one is easy. Please look at the patient as a whole. Look at each point that I have mentioned: the decreased vision, eye pain.
1 minute is over, and most of have answered as a neuroretinitis. I'll end the poll, man.
Yeah.
Now we can answer.
Yes, y'all are right. It's neuroretinitis. The only other positive history was her owning many cats as pets. This is how her fundus looked like, and she was positive for Toxoplasma IgG. So, asking about the history of having pets is also very, very important when it comes to a case of optic neuritis. Okay, I will give you the next question. A 24-year-old presents with disorientation and sudden loss of vision in both eyes. He says that he got up in the morning and had complete loss of vision. He has a lower limb spasticity, grade 5 power, brisk deep tendon reflexes. On examination, he had fixed dilated pupils with a normal anterior segment. The fundus examination showed a severe papilledema. This is the MRV. If you can see, this is how it looked like. There is void of flow in the posterior circulation. If you can see, if you can compare the right and left side, there is a thrombus there. So how would you treat the patient? Please look at the options.
We'll launch the poll, ma'am, for the option.
Yeah, yeah.
So, see the options are acetazolamide, lumbar puncture, low molecular weight heparin, and venous stenting. Please start answering. Only three, four. Be quick, you can just click. You don't have to copy each other. 20 seconds more. Okay. So most of them have answered as a low molecular weight heparin. Can we go to the answer?
Fabulous. Fantastic. I think I have done you all justice with the lecture then. So the thing about this boy was he was 24-year-old. He had come completely disoriented to the OPD in Madurai, Arvind Eye Hospital, and he was a chronic alcoholic and a smoker. He had a CVT, and he had episodes of giddiness and weakness of limbs a month back as well, which he did not tell the relatives. Only in this episode they came to know. And yeah, he was given low molecular weight heparin. He did improve, but the vision was not completely restored. So yes. So what is the magic mantra of getting a diagnosis right? What everybody says, it's the same thing. You take a proper history, you do a detailed examination, you do all the relevant examination according to what is your primary diagnosis. Do not ignore the differential diagnosis. We see book pictures in certain cases, but mind you, not all the cases that present to you will be book pictures. You will have to think of all the possible diagnoses, and you will have to visit and revisit the history again and again You will have to probe the patient and the relatives to ask what could be the cause of what he is presenting with. Prompt referrals, do not hesitate to my, this is especially to my neurologist, neurosurgeon, endocrinologist, physician friends, and pediatricians, that prompt referral is what I would say is of most importance, because we have to see the patient as a whole. At times, the condition may need intervention from all these specialties in order for the patient to get all right. Only ophthalmic management by giving, just steroid eye drops or anything is not going to help. And most importantly, don't stop till you get to the root of the problem. Search for the problem, do the investigations. In neuro-ophthalmology, I follow a protocol in which, after the patient comes to me, when the patient is coming inside, I look at the face, the facial symmetry, whether there is an abnormal head posture, especially in the nerve palsy cases which come in with a sudden head posture change. The person says he can't see double because he is obviously having a head tilt or a face, a shift to the side. And these things are of utmost importance. Once the patient comes and sits in front of you, always do an undilated examination first, so that you can see the status of the pupils. See the patient as a whole. Please take the general examination as you have been told to do when you were doing your MBBS. Do take the past history of the patient, whether he has had similar episodes in the past. Do take the medical history of the patient, the surgical history of the patient. In kids, in children, please ask for the birth history, the relevant birth history. A lot of these cases which present to us, which we feel are disc edemas without the patient complaining, may just be a congenital abnormality of the disc. So please don't forget that. And once you're done with it, please do your confrontation if you do not have the perimetry available. Please do your torchlight, flashlight examination to rule out RAPD. Do the color vision test by Ishihara, and now you have apps for it also. If you have gone for a camp, you don't have an Ishihara chart with you, please download download the apps which have it. Everything is available online now. And your red desaturation, just take a red pen and ask the patient to close one eye at a time and tell you how deep the red that they are seeing is, whether it's any different in either of the eyes. And of course, after that, all the investigations, slit lamp examinations, everything needs to be done. In cranial nerve, examinations should not be left, because you might be dealing with something much more than what looks to the eye. It might just be a disc edema that you're seeing, but when you do the cranial nerve examination, you might realize that the other nerves, other than the optic nerve, the other nerves are also involved. So that will also give you a clue to what is wrong with the patient. So don't stop till you get to the root of the problem. Order wisely, order the investigations wisely, so that the patient doesn't have to shell a bomb for getting a diagnosis. And once you have the diagnosis, please do not treat with steroids inadvertently. Don't excessively treat with steroids. Follow the protocols that have been set up, and you will be doing a lot of good to the patient as well as to yourself. So thank you for your attention. Now I'll be taking questions.
Yes, thank you, ma'am, for that very informative lecture. And there are a few quick questions we'll take, as already we have crossed 8:10.
Okay.
Is the CSF diagnostic even when the MRI have no features of multiple sclerosis? Like if your MRI comes normal in retrobulbar, do you still advise patient to undergo CSF? That's the question.
If the MRI comes normal, no, if it's the first attack, I don't. If it's the first attack, I don't. If it's the second attack and MRI does not show any plaques, doing a CSF for oligoclonal bands would not be advised unless you see other parameters in the blood investigation, like the ESR, CRP, everything, and you refer to the neurologist before you advise for a CSF. Because in multiple sclerosis, it's not only the eye that gets involved. There is weakness of limbs. There are other factors which you might miss on. So first, you do see all of that before you go in for an invasive kind of examination. Yeah.
If are there any clinical signs to differentiate between disc or like clinically between an NMA or optic neuritis?
Yeah, I have mentioned it before. Clinically, um, the optic nerve edema in a case of optic neuritis is lesser as compared to in a case of NMO or MOG, and the attacks are more frequent. And when you do the MRI, it is clearly visible that the perineuritis is more in a MOG antibody associated one, and longer segments. In fact, it may be as long as even reaching the chiasma. There might be cases in which the enhancement of the optic nerve might go up to the chiasma. And these long segments, you have to be very wary that they are not multiple sclerosis, they might be an NMO.
And the patient of optic neuritis presents after like 4 to 6 weeks after he started blurring of vision, and he comes back to you with some amount of vision. Is there any need or indication to give steroid or IVMP, or you can just observe?
See, after 4 to 6 weeks, IV steroids will not cause a lot of difference, but here also you have to investigate the patient first. You have to see what the MRI is. If the MRI is showing inflammation, active inflammation, take up of the gadolinium, then of course you have to give something to lower the inflammation. So IV steroids need to be given at that point of time also. But the vision, the visual prognosis becomes guarded. Most of the typical optic neuritis, whether or not you give steroids, the end vision outcome is going to be the same according to the ONTT protocol.
Yeah.
So yeah, so whether or not you give steroids, the visual recovery should be like if the patient is presenting to you at 3 or 4 weeks and the vision is still not recovered, then you have to raise the pointers as to whether this is typical optic neuritis or not. And if it is, then if there is enhancement, then you need to look further. You need to do the blood test, confirm that it is a typical optic neuritis, and then give steroids if needed. See, steroids, in fact, even in AION, NAION, not AION, but NAION, the controversy behind giving steroids is because there is active inflammation of the nerve, right? So steroids should help. So many people do give steroids if the patient presents in the first week with active inflammation of the nerve. They say that giving steroids does help lower the inflammation faster. But on the long run, the visual recovery is really, it's very controversial whether giving steroids in AION also helps. Though in optic neuritis, the vision recovery becomes faster with steroids. So it has some positive this as well.
Fine, ma'am. I think we have answered almost all the questions. And Dr. Emily, yes, we can get the MRI done in India, and yeah, with the indications like optic neuritis, it is covered under insurance. I suppose. So, thank you, Susha ma'am. And if any questions still, we'll be uploading this on YouTube, and you can still put the questions, and we can get back to Susha ma'am for our more queries if there are any. Thank you.
Yes, yes, definitely do get back. Sumit will share my email ID with you. It's eyedrsusha@gmail.com, I Dr. Susha at gmail.com. So, in case you have any queries, you can mail them to me and I'll see to it that I answer them personally uh, as soon as possible. Yeah.
Thank you.
Thank you very much. Thank you to BOA, Dr. Swapnesh and Sumit. Thank you very much for giving me this opportunity. I hope I have been able to uh, put some light on disc edema, and hopefully, all the people who are listening have got something extra from me.
Yes, yes, ma'am. And we'll meet again on Thursday, 7 p.m. with the next lecture in the series. Thank you all. Good night.
Thank you.